the fentanyl, but there's also other things beyond that. So we don't really know what caused that. But he was far away from our clinic, and there was an OBOT or Suboxone clinic in his hometown, but he didn't want to go there, and everyone there uses drugs. He said he couldn't even leave his house. So he came to see us. I guess we're the nearest program to him. Is that actually true? That can't be true.
It's not the nearest program, but the nearest one that provides anonymity.
Okay. So he wanted the anonymity as well. But he doesn't really have the resources to come here easily. He depends on his parents for his housing, his phone. He uses their home phone for the random callbacks, which are going to be important. And he uses his parents for rides to the clinic, which are very long. He's really, his listed medications are Lexapro, Vistaril. We put him on Suboxone 8 milligrams daily initially, or he was already taking, and we upped it. But his drug history was most of his actual medications. I doubt he was taking any medication regularly, and his drug use history at intake in November was marijuana since 11, most recent use 2 days ago, drinking since 13, most recent use 3 days ago, OxyContin since age 17, most recent use 1 year ago, nasal oxycodone since 17, most recent 5 months ago, nasal hydrocodone since 17, most recent use 6 months ago, Dilaudid from age 19, most recent use was 2 years ago, IV. But he had an overdose just 2 days prior to his intake. He started heroin at age 20, and the most recent use was the use that caused the overdose. 2 days prior to intake, he said it was 1/10 of a gram. So it probably wasn't heroin, probably was fentanyl. So he used roxicodone since age 19, but not in a long time. Benzos since age 20, and he said 1 week ago with just 1 bar, but that story became much more later. I'm not sure what the final decision was on how much benzos he actually used. He had reported cracking cocaine from age 15, but not using in the past 3 years, and Adderall from age 18, also not used in the last 2 to 3 years, and meth since age 16, but used in the last week. So he began using street Suboxone at age 21, and the night prior to coming to us for intake. This was among the more severe substance use histories I've ever seen in a person of this age. But his initial drug screen showed only the Suboxone, and I said it was consistent with provided history because we don't ever detect heroin anymore. We just don't detect fentanyl and assume that that's what it was. So, I'm going to kind of describe his clinical course. He had, I've already said the first part about overdosing, and he was given 8 milligrams the first day with thinking this would work great, but then by the very next day when he returned, he had a 7-minute seizure in the group and was sent to the ER, where he was sent back home and didn't return to us until the full week later. But oddly, we started doing really well. It got off to that rocky start, but for the next 30 days or so, we did well. He didn't have any issues staying sober. But because he had that seizure, I warned him, I'm going to be calling you back in. I want to watch you. I know it's hard to get in here, but I need you to answer your phone. And he had given us his parents' phone. The very first time we called him, it was about a month in, no answer. he said, oh, I just didn't get my parents' voicemail checked. So at the time, and I realize now that this is not the way that WVU is doing it anymore. We were immediately escalating care on the first missed random phone call. And so we tried to do that, but he said, I can't come more than once a week because I depend on rides. I can't do your IOP program because you're in person. And I'm not willing to do my local program. So I came up with this plan of making a special like check-in by video and just do witness dosing on some of the days and salivary drug screening on some of those checks. And he did that really well. We didn't have any issues for a few weeks, and then we decided to just stop it. Everything went amazingly well up till a full 90 days of sobriety. He would just come in weekly for his full in-person visit, totally negative drug screen, and reporting sobriety. And so at 90 days, what I've always, well, I don't say always, but very early in my practice, I started doing is I warned people at 90 days because we were having a lot of relapses right when we went to those longer prescriptions. I would warn them, I'm going to call you in randomly. So don't think, that this longer prescription is a trigger or is going to tempt you. And I did that for him, but he still didn't answer the phone call when we called him in. And then he didn't even return the following week after missing that phone call. That was his second failure to respond to random. Just this very morning of the day we're on today, he returned to our program 3 weeks after being out of it. And I jumped at this opportunity. I said, come on down, come back. Of course I'm worried about this guy. He needs treatment. But if I were to manage them according to our now ancient, they're just a couple years old, but they're now ancient protocols that pre-COVID, we would have discharged him from the program, maybe even for more than a month over recurrent missed randoms and with our old program rules and the very old coach rules, which are very old as a year or two now. So, but still, I just took the chance. I saw him this morning. What I actually did with him this morning is I tried to make him go to IOP again in person. He said he would not do that. Absolutely. I said, well, you know what? I'm going to talk to the great folks with WVU Coats and see what they think would be a protocol we could adopt that's within the power of my program to offer that could work for you. And so I'm going to use this case to investigate that. Also, when he came back this morning, he admitted to using a whole bunch of basically everything. Oh, he's been relapsing. Yeah. All right. So, would you scroll back up just a little, please? Because I got off. Okay. All right. So our purposes are, we want to try to clarify what the current code's practices are for managing infractions of diversion prevention protocols, understanding that, of course, we can't all have the exact same practices, but we at least can try to understand how COATS is doing it with this rapid changing environment. In particular, I want us all to discuss the legal, limits of what we can do and how it's changing with COVID. And so what are the appropriate prescribing practices and responses to infractions of diversion prevention protocols? I'm going to try to develop a consensus. I don't think I will, but at least maybe some agreement amongst us all here about what practices we should avoid, when we should say no, when we just can't prescribe anymore in this situation. This is just too. And when we do that, it's been tough for us, excessively tough, because if we only think of the patients, we almost never want to stop prescribing. but we have to think of our programs and our prescribers and the risks to them as well. How much do we have to consider those risks? And of course, I think with this last question of how long should this patient and similar patients have to wait to return to treatment after multiple infractions is probably going to get answered widely with not at all, but we'll see. The old answer from long ago was 6 months. We had a 6-month rule when we had diversion infractions. And that was from codes. And then just sort of, let's all just kind of speculate a little together on how much protection COVID gives us to actually be lenient on our policies and even on the laws that exist. So I actually copied in the entire actual law of not the entire, but just the diversion prevention part for people to see into the case. It's, so this is a straight copy from something called State Code 6912, which is actually why we do this, why ECHO exists in my view. I begged Dr. Berry to create this ECHO and work towards creating a coalition of prescribers to try to deal with the stigma that this law has created in West Virginia. West Virginia is one of the very few states to have such aggressive regulatory environment for physicians. And so this, you can see that it's a very aggressive law. I talked to Dr. Berry earlier today, and he was of the opinion, and I agree, that probably during COVID that this framework, this law is likely very relaxed, that we're not likely being expected to stick to it. But COVID is coming to an end. I wonder if we will, how much will be held to it, and a lot's left to interpretation. I'm not going to read the actual text there, and hopefully you've all read it by now as I rambled. All right. I also provided something here from Olivia, who has been amazing in keeping me updated on how the COATS model has been dealing with this issue. But this was more of just an email exchange between the two of us from a few months ago, where she updated me for some circumstances on how it was being done to deal with the COVID. There's a lot there to take in, everybody. So I'm not going to skim it all. I think it'd be better just to start taking questions. I've already talked a lot, unless you guys want me to go through all that.
Thank you so much. Do you guys want me to keep this up or just want to open the floor to discussion?
Dr. Morrison, I first want to just say kudos to you and your team. It sounds like you did a wonderful job trying to figure out a way to meet this patient's individual needs within the context of a structured program. And I know for me and my colleagues up here, that's one of the things that I struggle with the most is I want to be able to meet what I consider my patient's unique needs, and trying to do that in the context of having to stick to the accountable structure that we have, because that's what's best for all 400 patients that we have. It's a hard balance to do, and I think you guys did a wonderful job.
Thank you so much for that. Does anybody else have any questions or comments they want to discuss?
Ryan, there is a literature about using photography to do pill counts or film counts, and to have the patient take an image of their medication and send it to a provider to count what they have. You know, as far as bringing someone in for a drug screen, that's more thorough than what you could do with like a saliva test. You know, that's, there's no way around that really. But I've never done the photography method of pill counts, but I know at University of Maryland, they were doing that for a while. So I know it's done.
Ryan, I don't know about the 6-month thing. I mean, typically 6 months is only if we like have confirmed diversion, like we find out someone definitely is selling something. I mean, if somebody's missing screens and they're like kicked out of group, so to speak, it would be 30 days is typically the maximum we would do. Now, just looking at the legal stuff, it doesn't really give a minimum or anything. It seems like it's at the purview of us. So I don't think you'd have any like legal problem saying, okay, I'm not going to prescribe anymore until he shows up for his screen or does it. But you're not going to get in trouble if you like let him right back into clinic right away. Does that make sense? I think 6 months we've only held for people if we know there's actual diversion. Now I get it that if he's not coming in for the screen, then there's the concern of it, and maybe you could read the law like that. But I wouldn't necessarily jump to it being diversion. I would jump to non-compliance. That's where I would go at and say, you know, maybe he needs to be out of clinic for a little while, but I don't think you'd be in any trouble just letting him back in the way I'm looking at it. And I would say that would be what I would argue should be the consensus. If there is definite diversion, then it needs to be a long period. If it's not diversion, just non-compliance, then it needs to be a much shorter period, like a month maybe.
For our patients who we couldn't get in to do our pill counts, what we do send them to their pharmacist, and their pharmacist would do the random pill counts for us. So that was pretty helpful.
Dr. Husted, when you were saying that confirmed diversion is 6 months, but non-compliance is maybe a month, but you're okay with letting back in, are you implying that at WVU that maybe if he were to not do the next random that he should not be allowed back in for a month? Or am I misreading that?
You know, normally what we do is if it's non-compliance to screens, Olivia knows this a little better than me, but typically they have to be seen more often, or maybe we're not going to even prescribe until they come in for the screen, but we're not necessarily going to like ban them from clinic, because usually we'll just keep escalating their care until there's nowhere to escalate to. But I don't think we'd necessarily kick someone out of clinic for missing screens to a point. I mean, you could do that if you think he is truly diverting or not complying, but I don't think that would be our automatic thing, would be just to kick somebody out for missing screens. So I don't think you're doing anything wrong.
Where this patient had made 90 days sober, he was phase 2, so I think he would be okay to escalate his care just to phase 1, and that would be within what he can do still. If he were to miss another, he would have to do the IOP. You know, the medical team that reviewed it this morning, or the folks I had with me, were all thinking more of we needed to hold his feet to the fire and just make him make it happen for showing up more than once a week, at least for a little bit. So that was the most challenging thing for me, to overcome variations in staff perceptions on what's the most appropriate response.
And some of that is a little, you know, you kind of have to judge it based on your interactions with the patient. I know we had, you know, just here recently, we had a case where we were like not sure what was going on with medication. Instead of progressing to the next level of treatment, we chose to intensify, you know, 2 levels of treatment. We see them every other day. They're required to come in once a week for a medication count as well as a screen. And if they missed a screen, then we would only give them enough medication to get to their next screen and kind of go from there. So like, you're keeping track of the medication, you're monitoring how much they have each time they come in, but if they aren't coming in when they're supposed to and presenting when they're supposed to, then they're only getting medication until they come in. You know, they have to come in to get further medication.
Dr. Morrison, I might have missed the 3 weeks of his absence. What was he using? Was he using any substances or alcohol?
Yeah, heroin and meth.
Can't hear, I'm sorry.
Heroin, meth, benzos,
I heard heroin and meth in there, maybe?
Heroin, meth, benzos, and marijuana.
Okay, how often?
Four Xannies 4 days ago. That's all the elaboration we've got.
Okay, so he didn't really disclose like how often, frequency, amount. Okay. You know, and is he against inpatient treatment whatsoever? Is that like a definite no?
I'm gonna predict a no. I can't say definitely a no.
I haven't had any luck with anyone willing to go. Just, you know, trying to be optimistic. Okay.
You know, it does depend, like we talked about with the ASAM levels of care too, like does he truly need inpatient? Just because he's using some doesn't mean he would meet criteria for inpatient admission. And if you tried to push him into it, he probably wouldn't get it paid for insurance wise. So you do have to be careful about that. Use alone does not necessitate hospitalization. So.
Well, and you know, he had had previous seizures with, you know, with stopping the medication, and you know, of course, I wonder, you know, with the telehealth, with doing it that way, if there might have been some use during that period of time as well. So I was just thinking about all those things.
Yes, so we at Cabin Creek unfortunately don't follow exactly the way WVU has with the telehealth. We bring them in, so we get actual urine, but it's honestly not much better than salivary anymore these days because we can't detect half the stuff people use on a prelim urine. So even a send-off urine is missing a lot of stuff. So, but I just my impression of seeing him in clinic during that time was that he was staying in recovery and maintaining sobriety for 90 days. He seemed to be making progress.
I think personally, I would feel comfortable, you know, doing once a week visits and see how it goes from there, and see if he's compliant and whatnot, and doing well and making progress in his recovery.
Thank you so much for everyone's feedback and comments. Please update us on this patient. Dr. Morrison, thanks for, you know, presenting a case today. I really appreciate that as well. All right, if we can move forward then, I have Olivia up for her presentation. I have made you a co-host so that you could share your screen. So whenever you're ready, you can go ahead and do so and start.
Alrighty, let me see. Sorry, my computer's being slow.
No worries.
Alrighty, so I am going to be talking about confidentiality in groups and why it's important and how to kind of navigate that, I guess, So confidentiality in groups obviously is very important. It's also very challenging having it be telehealth versus in person. You know, even in person, it's difficult because you can't guarantee that the information isn't going to go anywhere. You can't, you know, promise that. You can encourage it and point out like why it's important and how important it is, but there's no way to guarantee it. It's also very important because it can determine the cohesion of the group, whether or not the group trusts each other, how their therapeutic process is going to go. So there's a lot of things that depend on confidentiality. You know, when confidentiality is broken in the group, it creates a lot of tension. The group they don't want to talk, not about things that are actually important and are going to help them progress in their process. You also get, you know, a lack of overall trust, not just within the group, but then they start to break down trust with the facility or organization that they're with. So it makes it harder for treatment overall. You know, on the flip side of this, when you are able to maintain confidentiality in groups, it can do a lot of different things. You know, it creates an absolute safe and secure environment so that patients are able to talk about things that are going on in their life, and they're able to find that camaraderie to be able to work through that, to get advice and different points of view and autonomy within the group. You know, so it's important to remind the group constantly just how important confidentiality is. It's hard sometimes, you know, we're so used to confidentiality that we don't always think to bring it up on a constant basis. I know before telehealth, I didn't, you know, every once in a while I would bring it up if I noticed something, but it wasn't something that I was saying as often as I should have. You know, just pre and post COVID, you know, pre-COVID, it was a lot different. You could control who was in the room, whether people were entering, going. You were able to provide that secure space. You know, people weren't walking around Walmart trying to do group, or, you know, just not, if you know that your patient, you know, has a spouse that's in group, in a different group, it's hard to control if they live together, if that person's in the room or not in the room, and they may have headphones in, but they may not, you know, that person may not be able to talk as openly as they want, just because of that as well. You know, during COVID, it's tough. You know, you have absolutely no control over who the patient is in the room with. You can always remove them from the group, but it's still, you know, at what point do you stop doing that? Because you're not going to get any treatment if they're not in an area. And, you know, we can't always see who's in the room. We can ask them to do like a 360 phone sweep, but that doesn't mean that they aren't having people walk in the room 10 minutes later or 5 minutes later. So that makes it really, really hard. You know, you also, it's hard to get the group to connect via telehealth. It's a different kind of connection. You don't get as much emotional response from the group. Now, some groups are totally different and some really thrive with that, but overall, it's hard to get that connection and that feeling of support and over telehealth. So some kind of just examples of people not adhering to confidentiality is inviting others into the meeting, so having people in the room, screenshotting. That's something that has started popping up more. People are screenshotting the group, which is definitely not a good thing, especially if they have all the little squares up so that everyone that is in the group can be seen. Not having headphones in and walking around Walmart or wherever they're at, which is something that we can, you know, control to an extent. We can remove them, but, you know, at the same time, we don't always know, especially if it's just you know, their face. You can't always see what else is going on. So how to address it? I think it's really important on how you address confidentiality when you're going into groups. I think that can personally make or break the adherence, as well as the overall thought of it. Reminders frequently. I think it's really important to just remind them why it's important. And I think it's also, you know, we need to explain why. It's as juvenile or, you know, as it may seem to explain why it's important not to say anything outside of here. You know, it's not always going to be inherent for a lot of people to think, oh yeah, I shouldn't say that outside of here, and I wouldn't want my information broadcasted. So I think it's very important to just to make sure that we're reminding them, you know, we need to make sure that we're keeping this information here. We need to make sure that, you know, we're not taking screenshots and other people can't hear or see what's going on, and, you know, that it's important because this is personal information and things like that. You know, and kind of with the why, just make sure that they understand. Nobody, you know, it's hard to follow rules when you don't understand the why. You know, if you don't understand the why or how it impacts you or impacts other people, it's hard to feel the need or the connection to the importance of it. And you're kind of you may want to bucket a little bit or just say, oh, it doesn't apply to me. So if you explain the why and the how, then a lot of people will understand why it connects to them and why it applies to them as well as everybody else in the group. I put a couple scenarios together and like best case practices of like, what should you do in this scenario? What can you do? You know, none of these are clear cut. You can really do just about 5 things for each one of these. So Alice has joined the weekly group. She's not wearing headphones and she's sitting at sheets. 3 people walk behind her. You know, you could really do a couple of these. You know, you can continue to remind Susie that she needs, Alice, change the name there, that she needs to put headphones in, that she can't have people walking behind her. You can remove her from the group immediately and just get a hold of her afterwards. Or you can just let her do group at sheets and let her know that she can't do that in the future. So personally, you know, for confidentiality reasons, the best answer is going to be B, is just remove her and get a hold of her after and explain everything. Depending on, you know, if it's right at the beginning or whatnot, you could even just do A. You could remind her and be like, hey, listen, you have to put these headphones in. This is important. You can't be around other people. But, you know, if you've reminded her a few times and it's still, you know, either she doesn't have headphones available or there's still people walking around and she's not able to get in a space that's private, then you'd want to remove her from the group. Just because if we can see, you know, the screen, the people behind the screen, then they can see the people on the screen. So it's important to make sure that she's removed and it's explained to her. So the important part is, you know, getting a hold of her afterwards and talking to her about why she can't do that and why she has to be in a very confidential space. So Henry's in his group, no issues at first, but then, you know, he's on mute, but his mouth is talking and he has no headphones in. So, you know, you see him And you wonder, are you talking to yourself or what's happening? So, we suspect that he's talking to somebody else in the room, but he doesn't have headphones in. So obviously there's someone else. And if he doesn't have headphones in, that other person can hear everything that's going on in the group. And that's other people talking about things that are important and personal to them. At this point, we don't really have to remove him immediately, but we should stop the conversation and ask, Henry, if there's someone in the room, and address it, and provide education on, hey, listen, we can see you talking, but you don't have headphones in. Because providing that explanation and letting them know, like, we can see you talking. We can see that some interaction is happening and you don't have headphones in, and whoever's in the room with you can hear what is happening in the group. And that means that, confidentiality isn't happening. It allows for an opportunity for education to be given to the whole group and for good conversation to be had around it, depending on the group that you have. And then, another part of confidentiality is, you will have patients that are in relationships or that used to be in relationships. And it's important to make sure that both parties, whether they be in a relationship and comfortable being in the same group, that, it's not best practice, if at all possible, to have them in the same group. Because, they could be fighting, things could be going on, or they could break up. And there are things that people don't always share with significant others, when it comes to very personal things. So, Kate and Lee are in a relationship and they're in the same group. Well, what do you do? If she reaches out and says that she's not comfortable and this is, something that she's not okay with, when at all possible, you're going to try to change one of them to a different group. You're going to want to make sure that each party is comfortable, each party's information is as confidential as possible. And you also want to make sure that even though they know one another is in group, that they're not talking about anything that is going on. It can be difficult to reiterate the importance of confidentiality in groups at times, especially when, they're busy and they're trying to get from place to place and they're trying to ride the bus, or, they have to take an Uber places and things like that. It's, I always stress the importance of headphones, but it can be very helpful if you just explain why it's so important, because they don't always understand that. They may not care if their information is spread out to everybody, but they don't always understand that other people do not want that same thing. Any questions about confidentiality?
I was just going to say that, when you intervene with these things, these scenarios, you set a precedent, and making an example of somebody who's breaching confidentiality in some way helps the group kind of organize and make it a secure, safe environment so they can get work done. And so it's important to hop on that right away and make sure people are adhering to the principle.
Something I do is I go over the rules of the group right at the beginning with everybody. And then during it, if somebody needs to get up and go to the restroom or use a phone or do whatever, I just ask them to let the group know. So listening to you all from the very beginning with other presentations, Olivia as well is here, I've learned, what to do and what not to do and how to set a precedent for everybody else. And it seems to be working real well. I haven't found that anybody's been resistant or obstinate with it. Everybody's pretty good.
Absolutely. And that's something that we do too. Like every single session, our medical assistants go over, you know, that people need to be in a confidential space or have headphones in. And occasionally we'll get those that like to go to Walmart, but not too often.
I don't have a question. I just wanted to say
Thank you so much, Olivia. That was a great presentation and so important. I think that, you know, a lot of people need to know the why and clarify whenever you're explaining something to somebody. I think reminding any of us sometimes is really important. I do have a couple questions from a participant. This could be answered by a medical or behavioral health specialist. The first is, how does one build a personal relationship with a patient or a client in a group setting, especially when patients are reluctant to speak? So I didn't know if anybody had any insight on that. If somebody's already shy or reserved, you know, how can you kind of build a relationship upon that?
What I recommend is to talk about the universality of discomfort talking in a group. So if a patient doesn't want to talk to me, I'll say, you know, I wonder, it might be interesting to see if other people find it difficult to talk in the group, and kind of undo the resistance by spreading it out among other people. And the other patients say, oh yeah, when I started out, it was so difficult, but I got used to it. Now I just say whatever's on my mind. And so they kind of learn that it's a common feeling to have.
I kind of make it like my mission throughout like the first part of the group or whatnot, to see if I can get them to like crack a smile or connect in some way. I use a lot of humor. I think it kind of lets down guards with trying to build that personal or relationship.
I also, as a way to just kind of foster a conversation among all of us, I will, so the first half of group, I'm usually doing individual check-ins with everybody instead of me calling on somebody. So let's say we're checking in with Derek right now, and Derek's done, then I'll say, Derek, who do you want to hear from next? And he'll pick the next person in group, and then that person will pick the next person. So it sort of hopefully keeps them on their toes so that they're paying attention. And also that's a small way for them to connect with each other.
Thank you so much. Those are all great examples. I think even the most open, and I'm a type A and I still get sometimes shy in these kind of settings. So I'm pretty much an open book. But yeah, I still get a little nervous. I think it's just a natural reaction. I think making sure they understand that or know that you can be vulnerable, you're being vulnerable, I think is helpful. That's just my 2 cents though. My second question is, when is it appropriate to request to meet with a patient or a client individually?
I would say anytime the clinician feels it's appropriate, like there's a clinical need. So if, you know, we're assessing behavioral changes throughout group and somebody who is more talkative is suddenly more quiet, we might want to pull them aside after group and say, hey, what's going on? Or if somebody's using more of an avoidance tactic, whether it's humor or whatever, you know, sometimes it's best not to call it out in group, and that's just kind of trusting the clinical judgment. Other times we use it as a kind of teaching method for the rest of the group and call it out. So it just kind of depends on, you know, how the clinician looks at it themselves.
Excellent. Thank you so much. Does anybody else have any further questions or comments? Always like to give you guys a little bit of time. Yes, but great job. Thank you so much, Olivia. And thank you so much, Dr. Morrison, for presenting. So you do get a little bit of time back today. I just will make that last announcement. The next session will take place on May 10th, and it will be with Philip West presenting Building Patient Trust. So nice segue into that. Thank you, everyone.
I wasn't able to use the link to to whatever that form was you needed me to fill out. It didn't come up on my computer, just kind of thought and thought and thought and never came up.
So sometimes with that link, I've heard this issue come across for some people as well. I think if you're on maybe like a work network, it blocks it sometimes. So no worries at all. We can also do it through email for anyone having difficulty with that link. I do apologize. It's a little bit of a tedious thing to get through. I appreciate it.
Thank you so much. Sorry about that.
And how do we, so you fill that out in order to get CME credit? How do we retrieve those hours from you? Does that make sense?
So we can email you all too in the recap today. We'll give you a direct link to get your transcript for the CME credits, along with the direct email address to our contact at the CME department here at WVU. So they'll be able to help get any credits that you all may need. So awesome. I do apologize. Everyone should be receiving one general CME credit for the sessions. So it's just a way for us to ensure that you all get that. They're kind of getting more strict on us, so.
Yeah, I think that Katie should be fine, but definitely make sure, follow that link. I think anybody that's been attending for a while, I feel like it's like a newer change, it seems and appears. So I don't believe I see any of your names on this huge list we have of reaching out to people, but if I do reach out to you, get back to me. Any other questions before I close? All right. Thank you so much, everyone. You have a wonderful rest of your day, and I'll see you soon.